what I do, and diabetic triopathy is what I think is relevant to practicing physicians. So I would like to thank Dr. Abdul Salam and Bashir to ask me to come here, but you realize what you've done by asking me to come here. Last night I was watching the Morocco game, and I've come here, but inshallah I'm going to be back for the final. Okay, so, very sensitive, I'm sorry. Yeah, so I'm going to speak on the diabetic triopathy, which of course is retinopathy, nephropathy, and neuropathy. And I'm deliberately Sure? Okay. I'm sorry. Okay. So first of all, I'm going to talk about painful neuropathy, which you'll be aware is common, affects at least 21% of people in North America, in Europe, but in this part of the world, we have studies showing that it affects at least 34% of people. So this is actually the most recent guidelines by Dan Ziegler and a host of other people on how we should manage diabetic sensory motor polyneuropathy. Okay, so you can see the green line at the top, gabapentinoids, tricyclic antidepressants, and SNRIs. If these work, fine. If not, you can combine with either of the other drugs. Then if these fail, you can think about other drugs like capsaicin patches, like spinal cord stimulation, TENS, FREMS. But really the bottom line is that painful diabetic neuropathy, at the moment, we have limited options for its management. There is now a trial that's just been published called the Option DM study by Solomon Tesfaye's group from the UK. What did they do? Well, they asked the question, if given the current drugs that we have, so if you have a patient in front of you with painful diabetic neuropathy, what drug do you choose first? Which drug would you use? Duloxetine. Somebody else? Gabapentin, pregabalin. So we have like these host of drugs that we've got in front of us, and what makes you decide whether you use pregabalin or gabapentin? Yeah, or the drug rep's been to see you and reminded you, and you said, okay, I'll try that. So what is the evidence that each of these drugs work, and if one works better than the other? So what they did is they did actually simulated almost what you do in the clinical practice, where the patient comes in, you start them on a gabapentin, it works, great, thank you, shukran, bye. If it doesn't work, I'll change you to something else, or I'll add another drug. Okay. So this is, yes, we're coming to that. But so what they did is they cycled through amitriptyline, pregabalin, amitriptyline, duloxetine, pregabalin. But the bottom line was this: all the drugs are equal, right? They all get about a 30% response, about a 50% response maximum. So sometimes obvious conditions and treatments are the most difficult to grasp, I say, and that's where vitamins come in, right? Which is that actually there is a beautiful relationship between low levels of vitamin D and painful diabetic neuropathy. And this is probably one of the least used therapies for painful diabetic neuropathy, because for painful diabetic neuropathy, like you said, we go to pregabalin, gabapentin, tricyclics, and we get lots of side effects, and we don't really get amazing results. So this is studies that we've done and in Sheffield, where we show in the green bar you can see people with painful diabetic neuropathy have less vitamin D compared to people with painless diabetic neuropathy compared to healthy controls. And in fact, the odds ratio for painful diabetic neuropathy, if you have a level less than 20 nanograms per mil, is almost 10-fold greater. So really, vitamin D levels are important for perhaps treating painful diabetic neuropathy. And in fact, we've done a study where, this is in Pakistan, where we took about 130 people with diabetes with painful diabetic neuropathy, and we gave them one shot of 600,000 international units of IM vitamin D3. I know everybody thinks we're poisoning them. We didn't, right? Perfectly safe, right? But look what happened to the pain scores. They all came down. And this was not because of the placebo effect, because a lot of people said, oh, you gave an injection, people think they get better. But actually, if you look at the timelines, it took about 6 weeks for the pain to start to reduce. And what was interesting is that in these patients, look at the baseline level. That is a very healthy level. If you saw that in your clinic, you'd say, okay, fine, you don't need to have any treatment. But you can see it went from 31 nanograms to 46 nanograms, and the pain scores came down. So my clinical practice actually is not to give IM vitamin D, but to give oral D3, 50,000 units daily for 10 days in the evening, and then I give 50 to 100,000 units once weekly. And I try to keep the vitamin D level around 50 to 60 nanograms per mil. And I have very, very happy patients who have no side effects and who have pain relief. The other vitamin, which I know is prescribed a lot in this region, and I actually personally didn't believe that it really worked as well as people claimed, B12 or B vitamins. But there's a lot of it prescribed. But there's now a study published this last year from Greece, which took patients with diabetic painful neuropathy and gave them simply oral B12, 1,000 micrograms against placebo for 12 months. And what did they show? Well, you have to compare the active group with the placebo group. And what you see is, first of all, look at the B12 level, baseline, 232. Now that, again, people would say is normal. It's not really low, right? So it's not deficient B12, but when they gave the B12 for 1 year, it went up to 776. As a consequence, the pain MNSIQ improved, the quality of life improved, even nerve conductions improved, pain scores came down. If you look at the placebo group, nothing much happened. So vitamins, I think, do play a role in painful diabetic neuropathy, and I think they should be utilized. The other thing that, so you're then left with, well, what else could be going wrong? Well, the other things that could be going wrong are actually changes at the genetic level in terms of not the nerve fibers themselves, but the receptors that are on the nerve fibers. And I together with a big consortium in Europe, actually, we did a big genetic study on painful diabetic neuropathy. And what we showed, very interestingly, is that if you take people with painful neuropathy, then about 21%, 1 in 5 individuals, have a variant in a voltage-gated sodium channel. And you think, what's a voltage-gated sodium channel? Does anybody know? Do you know what it is? I'll put you on the spot. Sorry. Very good. Excellent. Excellent. Well done. So that's excellent. So, most students, they don't know, right? But it's a voltage-gated sodium channel. So it's like basically it's the signaling in the end of the membrane of the nerve that triggers pain. Okay, so if you have a variant in that, then you get abnormalities. So we've shown that actually maybe up to a fifth people have this abnormality, and we haven't really looked at this. We then also looked at a number of other channels, not just sodium channels, but also hydrogen channels, potassium channels. And the bottom line is, when you look for them, you start to find abnormalities. So whether it's, hydrogen trip A1, but essentially there is an abnormality. And here is now actually a beautiful story of how these drugs have been developed for these sodium channels. So there was a geneticist who went from Oxford on holiday to the northwest of Pakistan, and he came across this child. Now, what do you notice about this child? First of all, he's walking on coal, right? So this is one of these street acts, and he's looking at this kid and he's thinking, why is this child being able to walk on? And the bottom line was that he then took some blood samples, and they found out that he had actually got the voltage-gated sodium channel mutation, and this was the first description back in 1986 of congenital insensitivity to pain. If I tested the nerve conduction in this kid, normal. If I tested their thermal sensation, normal. But their voltage-gated sodium channels were not working. And if you have no voltage-gated sodium channels working, you have no pain. Because of that, actually, there have been drugs now that are in clinical trials of voltage-gated sodium channels that are NaV 1.7 antagonists, and there are at least 4 of them in phase 2 for clinical trials. The other drug that you ought to be aware of is, I'm not looking at the females necessarily, but normally you use it for aesthetic purposes, but what you will know is botulinum is increasingly used for a number of other purposes, and one of those is actually painful neuropathy. So instead of injecting it into the skin to make you look more beautiful, what these studies have done actually is injected into the dorsum of the foot subcutaneously botulinum toxin, and what you see actually is results that are as good as pregabalin, good as gabapentin, in reducing pain for up to 16 weeks. So you can give botulinum toxin subcutaneously. Okay, and the other thing that we ought to be aware of is something that's new, is spinal cord stimulation for painful neuropathy. So this is a trial that's been published in JAMA Neurology, showing that if you take patients who have got very good glycemic control but have painful diabetic neuropathy, if you then put a spinal cord stimulator in, you can see the pain scores come down markedly. If you look at this, the average was around 7. If you give pregabalin, what would the score come down to? At best, maybe 5. This is coming down to 2. It's almost virtually obliterating the pain. So for the really, really difficult patients with painful diabetic neuropathy, this is a potential choice. Okay. For diabetic retinopathy, what do we have? Well, there are 3 potential therapies for diabetic retinopathy. So if you're in the clinic, apart from referring them to the ophthalmologist, there are 3 things that you can do as physicians. One is improve their glycemic control. And this is based on data from the ACCORD study, which had 3 arms: improved blood sugar control, improved dyslipidemia with fenofibrate, and improved blood pressure control with a target of 120 compared to 140. What you see is improving blood sugar control with a HbA1c of less than 6%, you can reduce the odds of developing diabetic retinopathy by about 37%. If you, however, treat with fenofibrate, guess what happens? You actually get a better result. And most people don't prescribe fenofibrate. But in Australia, there is now a license for diabetic retinopathy, and fenofibrate has that license. So it's something you need to think about for the treatment of diabetic retinopathy. And this is the data on which the license was given in Australia for diabetic retinopathy. Based on the fenofibrate trial, the FIELDS trial, 200 milligrams of fenofibrate against placebo over 5 years, what you see is macular edema, proliferative retinopathy, or retinopathy significantly reduced in those people on fenofibrate compared to those who were on placebo. And of course, there is also data actually to do with statins, showing again that if you're on a statin, you are less likely to develop diabetic retinopathy. What about diabetic nephropathy? Well, we know that diabetic nephropathy, the treatments that we give, will reduce proteinuria and don't really have an impact on GFR. They never improve GFR. They always, maybe at best, might stabilize GFR. So, what are the drugs that we have that would lower blood pressure? Well, we have lots of drugs, alpha blockers, beta blockers, but what drugs out of these classes work for diabetic nephropathy? Do they? ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, actually only verapamil, not the dihydropyridine. Spironolactone. So in fact, we're left with very few drugs that actually work for diabetic nephropathy. And so what do you do next? Once you've got a patient in your clinic who's on lisinopril 10 milligrams, and they still have proteinuria. And remember, and actually of note now, in this week, the American Diabetes Association new guidelines have come out where the blood pressure target has dropped from 140 systolic to 130 systolic. So that's now lower. But proteinuria is continuing. What would you do next? What drug? SGLT2, that's way down. Spironolactone. When was the last time you gave spironolactone? Hardly. People worry about, hyperkalemia, gynecomastia, but a small dose of spironolactone, 25 milligrams, and you will switch off proteinuria. So there is really very good data, type 1 and type 2 diabetes. And in fact, there is a Cochrane review that has shown that if you give spironolactone, you can reduce proteinuria by up to 0.61 grams. But spironolactone, eplerenone, and finerenone have all now been shown to have an effect on proteinuria. And so you're given spironolactone, and so this is actually the study. It's been published about 2 years ago with finerenone in type 2 diabetic patients, 5,700 patients with urine albumin creatinine ratio 30 to 300, EGFR between 25 to 60, given finerenone for 2.6 years. First, proteinuria comes down with finerenone. People worry about potassium. Potassium went up a little bit, but not really that much. But what was key is the following. Both the primary and the secondary composite, which is a greater than 40% decrease in EGFR and death from renal cause, or a doubling of serum creatinine and death from renal cause, significantly reduced with finerenone. And in fact, the latest American Diabetes Association guidelines say now finerenone should be that second-line drug after ACE-ARB for diabetic nephropathy. Sorry, what did you say? Finerenone is basically like a spironolactone. So, what next? Adequate blood pressure control? Well, vitamin D, my favorite subject. But vitamin D again has been shown in trials from the STINO to reduce microalbuminuria. This is activated vitamin D. But 1-alpha again reduces proteinuria. What next? Well, GLP-1 agonists. So we know from all the major cardiovascular outcome trials that if you look at nephropathy, you can see here has a significant reduction in renal outcomes, which, by the way, are new onset microalbuminuria, doubling of serum creatinine, and EGFR less than 45, or the need for renal replacement, all significantly reduced by about 22%. Although, remember, there is a signal for retinopathy for GLP-1, and we are waiting on a trial ongoing at the moment for retinopathy. And again, if you look at semaglutide, which Mohammed talked about, you can see again highly significant reduction in renal outcomes of about 36% in those on semaglutide. But again, a signal for retinopathy, which we need to be cautious about. And if all that else fails, then, of course, we have the SGLT2 inhibitors. And there's multiple trials actually with empagliflozin showing you can see reduction in primary outcome, a flattening off of the EGFR with canagliflozin and with dapagliflozin. So that's 3 SGLT2 inhibitors, all have been shown to have an impact on progression of diabetic nephropathy. Thank you.